For the next 30 minutes, we're going to do like a really focused talk. I just want to kind of give a little primer. So for the next 15 minutes, I'm going to talk about cervical spine injuries. And then for the following 15 minutes, we're going to talk about thoracic trauma. We're going to make this really, really simple and focused. We have a tremendous new amount of evidence in pediatric cervical spine injuries that was just published in July of this year that should really further simplify how you standardize the approach of every kid who has a potential neck injury. We're going to talk a little bit about how kids' necks are different and just kind of the general concept of how you should think about kids when they're injured and thinking about their neck, not forgetting it. But we're really going to keep this simple with one simple decision rule that I want you guys to take back home. So just remember, kids' necks are different than adults, and really they don't make adult-looking bodies until they're about 8. So the way my old trauma surgeon used to explain it is kids are just bowling balls on a toothpick. That's all they are, right? You see them walking around, they got this huge head that just looks like it always wants to fall over with a little skinny neck that can barely hold it up. And if you're in a car accident or some other type of major velocity injury, that can be an issue. In addition, their muscles are not as strong. The actual vertebra, the facets actually sit more horizontally, and so their types of injuries differ. What that really means, and this is just a concept overall in trauma, you guys already know this, but the good thing is that kids bend. They flex and they bend and they don't break. And so they can get injuries in different locations because of the way that their anatomy is different. That's different than an adult. And really, to make a long story shorter, they get upper cervical spine injury. So I love this picture, right? This is the strangest picture in the world. You got gigantor baby on the left, and then you got normal human on the right. But this is supposed to show you proportions, which is accurate, right? A kid's head they're not supposed. They look weird. They're like aliens, right? They're just these big round balls. And so you got to think of that whenever they're falling and having injury. And again, the thing I just want you to remember is if a kid does have a spine injury, and let's just, before we start freaking out about this topic, it's a relatively unfrequent injury. At the most, maybe occurs in about 2% of major trauma. But when it happens, little kids get injuries to their upper cervical spine. That's a scary area. Almost classically above C4. And that's because that bowling ball in the fulcrum happens higher up top. And it can be tough, right? You ever try to palpate the top of the posterior cervical spine, it can be tough. So you really have to have a method in which even before you go and examine that kid, you're thinking, is this maybe high risk for a cervical spine injury? Do we have the right type collar? I'm not going to really talk about collars, but if you don't know what collar you have, make sure you know how to apply it. We use Aspens at our site. And Aspen specifically has a great YouTube video to teach people how to look at the dots and make sure a kid is properly placed to make sure you know how to use it. Of course, there are exceptions to every rule. This kid has a lower cervical spine injury, but in general, they have upper spine injuries. So again, relatively uncommon. We're talking about 2%. And clinical decision rules are what are going to help us. And there's a lot of slides in this talk, and there is one money slide that I want you guys to just remember that summarizes all the research around clinical decision rules over the last 20 years, and it just came out in July of this past year. But before we get to that, this is what we're thinking about when we think about decision rules. You're only thinking 3 things, right? Can I clinically clear this kid that was put in a collar maybe before they came? Can I get away with just a plain x-ray, or do I have to scan them? Right? Like when you're thinking about their neck, that's really what we're thinking about. In major severe trauma, as we all know, it's always easier, right? When they're really sick, what do? You immobilize them, you scan their neck, and you keep moving forward to try to manage and stabilize them. But it's really the latter kids that are the ones that we mostly see every day. So what are red flags? What are the things that should make you stop before you even get past the exam and tell the nurse, hey, we forgot to put this kid in a cervical collar? It's anybody that has any of these findings. Most of these are self-explanatory. Some of these you know before, like high-risk mechanism injury, like the teenager who dives into a pool that has shallow water. But don't forget the kids with predisposing conditions. Don't forget your Down syndrome kids that have atlantoaxial instability at baseline. Those kids are different children that have higher risk for neck injuries. But again, these are just red flags that you're probably not going to miss anyway. And just the general concept is that if you have a low-risk mechanism of injury and an absence of these findings, then we should be able to clinically clear it. But it's kind of scary, right? Because it only happens 2% of the time, but what if I'm the one who misses it, and it's an upper cervical spine injury, and not just the medical legal risk, but the actual potential missing the harm is kind of what we all worry about, right? You want to also think about not over-radiating these kids, right? Because you also are like, I don't want to CT scan every single kid and over-radiate them for no reason. And you want to kind of do it the same way every time so that you don't have to be thinking, well, for this kid, do I need to do x-rays? And for this kid, can I just clinically clear them? That's not what you're going to be left with at the end of this talk. Just so you know, there are some places that have clearly implemented pediatric C-spine clearance that have been successful. Beaumont Children's is an adult facility that sees a lot of kids trauma that did this about 5 years ago, and they drastically reduced how many kids got imaged, how many CT scans could be done. So you could do this at your facility regardless of how much trauma that you see. I'm going to flash by this slide because I actually don't want you to hyper-focus on the upper left box. But if you're going to read a box, I want you to start becoming familiar and comfortable with what would be low risk. There are things missing on this algorithm. So this is not the one you're going to take home. In fact, it's missing specifically some things around abdominal and torso trauma. But it goes through pain, it goes through high-risk mechanisms of injury. And again, the reason why we don't just CT scan every kid is, of course, we worry about radiation. We've talked about that in the head injury talk. But CT scans of the neck are extra crucial because of the exposure to the thyroid, right? An exquisitely sensitive organ to radiation, with thyroid cancer being a very challenging disease to manage later on. I'm going to put in a quick plug for these, but we're going to kind of actually fly through these. Most of us who see adults and kids are very, very familiar with Nexus and Canadian C-spine, and you're like, there's so many patients there. Let's just use that for kids, right? That's, in the early 2000s, that was kind of like, well, there's so many patients in those studies, can we just use it? And the short answer is no. Because if you don't have enough kids that you're looking at in one of these clinical decision rules, you're never going to have enough cervical spine injuries in that population to then make a good rule. In Nexus, there were only 900 kids less than 8, and only 4 of them had injuries. So you're never going to make a rule powerful enough to not miss an injury. When we talk about any decision rule, we're usually talking about sensitivity. We're not going to get you did not come here for a stats talk. If you did, this is definitely the wrong audience, okay? But if you want something that's sensitive, you just want no false negatives. You don't ever want to follow a rule and it says it's negative and then you're like, oop, we missed one, right? You want something that's really sensitive. There wasn't enough kids in Nexus, and the Canadian rule excluded everyone that was less than 16. So this doesn't apply to kids in general. It's not strong enough. These are some pictures that are just summaries of what Nexus and Canadian uses, but they're not perfect. And when you do look at it at kids, their sensitivity at the most was 86%. That's not good enough, okay? And even with the low prevalence disease like pediatric cervical spine injury, the negative predictive value does not go up enough. Okay, so it's not enough. You can't just use those two tools, but they're on the right path. They're on the right path at looking at mechanism of injury, red flag symptoms, and again, this is kind of what Nexus looks like. This is what the Canadian C-spine rule looks like. But then there's PECARN. All right, thank goodness for PECARN. PECARN, you know well from the head injury rule. And PECARN, and Leonard you're going to see, so Julie Leonard is an amazing PEM doctor out of Boston Children's. She's just an amazing, amazing doctor who has made this one of her life's work. And so she did one of the biggest retrospectives back in 2011, and they really found 8 things that were high risk for injury. Kids with altered mental status, focal neurological findings, neck pain, both self-reported and by your palpation, torticollis, which is self-explanatory, I don't want to move my neck, major torso injury. This is the one I don't want you guys to forget. This is how kids work in trauma, right? Major injuries to here are right next to their neck. And so major injuries here displace a lot of force to their head and neck, and vice versa. So major injuries to the head or neck portend larger risk for hollow viscous injuries like liver and spleen injuries. So just don't forget that. You see a major seatbelt sign here, you should think, okay, what else could I be missing? Chronic conditions, which we just talked about, Downs and other kids, and then diving, which would be considered a high-risk mechanism of injury in major MVCs. Okay, so we got like a list of, again, kind of like Nexus and CCR, high-risk mechanisms of injury, high-risk physical exam findings. We've added now major torso injury because that is a risk factor. And then just in July of this year, PECARN has finally validated the pediatric C-spine imaging rule. This is what I want you guys to take from this talk. So they broke up C-spine injuries into 3 major categories. Kids who are high risk, and so very, very high risk. These kids have a risk of pediatric C-spine injury as high as 10%. You are never going to not image these kids. Altered GCS, abnormal airway breathing circulation, focal neurological deficits. You put them in a C-collar and you CT scan their cervical spine. CT scan exquisitely sensitive for bony fractures, a great tool to measure also spaces for blood. These kids, who are kind of in the equivocal category, still have a risk of clinically significant C-spine injuries of about 3%. 3% is too high in kids, and so we still have to do something. So kids who have a GCS that's in the middle, kids who have self-reported neck pain or neck tenderness when you palpate their C-spine, or kids with substantial head or torso injury. And down here, you can read what substantial head or torso injury, but to make it very simple, you got a skull fracture, you got big, bad, blunt abdominal trauma, you got those things, C-collar them and do x-rays. We're gonna talk about that. And then if you have none of these above risk factors, your overall rate of C-spine injuries is less than 0.2%. Which really is enough to stand on to say, I'm going to give them some ibuprofen, I'm going to make sure everything else is okay, and then I'm going to clinically clear them. Negative predictive value approaching 99.9%, so this is useful, this is applicable in day-to-day. So PECARN is what I want you guys to take away from this. We're going to talk about some injuries and then kind of circle back to this. Again, Nexus barely covered kids, Canadian rule excluded them. PECARN negative predictive value is strong, we should be able to implement this in practice. But you still have to use common sense. You're not going to forget the ABCs. You're not going to ever ignore bony tenderness. And you're not going to ignore high-risk mechanism injuries. If there's one thing that the PECARN new rule does not explicitly state, is the high-risk mechanisms of injuries, right? So I would just, again, application of these rules is the art of medicine. So I would not tell you that a kid who dove into a swimming pool that had no water and says, yeah, my neck doesn't hurt, that I'm going to be so cavalier as to say, yeah, sure, I'm fine not x-raying you at all, okay? So use a little bit of common sense application also. Just remember that if you do these things, it is safe to discharge them and clinically clear them. And again, PECARN is now given the data to back us up, both with the lawyers as well as in just good clinical practice. We've talked a little about imaging choices. Most of us are going to have CT scan and X-ray as our most commonly available test. CT scan should always be used for kids who have any specific neurodeficits, easy way to look for fractures, easy way to look for blood. X-rays are going to be the thing that you're going to most commonly use for most kids because most kids are not in that top category of altered mental status and abnormal ABCs. And so, again, you guys know this, but CT scan, which you can kind of see there on the far left, which you could see every little bit of the bone. It's really, in many ways, CT scan is better to pick up fractures than MRI. MRI is better for ligamentous injury, spinal cord injury, picking up just any kind of areas of fluid. But X-ray is a great screening tool. It can pick up almost 90% of major injuries. And so your test, when you do a plain X-ray, and we're going to kind of go through some of these things. Here you can see some wedging type injuries that were picked up on CT scan, and then this edema from fluid, which you can see on the white lighting up on MRI also. But for C-spine, Ideally, we're getting a 3 view for clearance. But I just want to caution you, kids less than 5, they can't do the open mouth view. They can't go while they have a collar on. They hate it. If you can get a lateral, that gets you almost 84% of all your injuries. You add a second view like the AP, now you're approaching up to 92, 93%. So your goal is to make sure everybody in your ER knows how to do a good lateral film. The lateral is where your money is for most pediatric cervical spine injuries. Plain film should be the most common imaging that you're using. And how to interpret it, I'm just going to say you should feel comfortable looking at them too. I could give a whole talk on how to look at the C-spine in kids, but just some general rules I want you guys to feel very comfortable with. When we're looking at the neck of a kid, we're always looking at 4 major lines. There's the anterior process line, posterior process line, spinal laminar line, and then spinous process line. You're looking for this normal curvature, and you're looking for any breaks in that curvature. In addition, you are looking to the space in front of the vertebral body and before that big thing filled with air, okay? It's called your airway. Up until about C3, C4, you see how there's not as much space there as when you get after C4, C5. The old school rule of thumb is that up until C3, C4, this space total should be less than half of the total width. You can also measure it, and it should be no more than 7 millimeters up top and 14 millimeters down there. In front of the dens, which is part of your odontoid process, you also want that space to be less than 5 millimeters. These are just some general numbers that we remember. And then lastly, kids are weird, and so they can sometimes have, you see here where C2 looks like it's in front of C3. There are some common pseudo findings that you see in kids. This is called pseudo subluxation. The way you differentiate this from a real subluxation is you draw a line. You draw it from the C1 posterior spinous process to C3. And you see how the C2 spinous process just naturally lays right on that line. If this line naturally hits all those parts, this is a pseudo subluxation and not a real one. Again, we could give a whole 20-minute talk on all the variants around pediatrics, but I want you to feel comfortable looking at the lines. I want you to feel really comfortable looking at that prevertebral space. It should be thin up top, thicker at the bottom. I want you to feel comfortable looking at the space in front of the dens and feel comfortable with pseudo subluxation, things you will see on every single pediatric cervical spine injury. There are real subluxations that can happen, and so here you can see that that posterior line, if we drew it, is not going to work. That C2 is off. Here you have like a normal one. You could get odontoid fractures, which is another fancy way to say the dens, that you're not going to miss that big crack. And you can also see subluxation further down also, okay? Which is down there, that's at C4. But like I said, the thing you want to worry about more in little kids is upper cervical spine injuries, okay? So I want you to really focus on things above C3 when you're finally x-raying that little kid who's 3 or 4 years old. I want you to really pay attention because you think, oh, a kid has a hangman's fracture, they're going to be paralyzed, they're not going to be breathing. You would be surprised how many little kids I've had that have had posterior spinous processes fractures of C2 and C3, and they're just sitting there looking at you. They're just, okay, like what's going on? It's not a stable fracture. They need to be immobilized. The mechanism is different than when you're getting hung. It's from that hyperflexion injury, and they can look okay. Okay. Remember just that C-spine injuries come in with severe trauma, and we already talked about that with blunt abdominal trauma. So kind of putting it all together, your approach to pediatric C-spine injuries should be this. You should have a clinical decision rule that you feel comfortable with. I would highly suggest you feel comfortable with the PECARN rule. You should understand that high-risk mechanism of injuries like blunt torso trauma and head trauma can have C-spine injuries. That little kids get injuries higher up and still look okay. CT those kids that are high risk. X-ray those kids that are right in that middle box. They got a seatbelt sign. They got a GCS that's kind of soft. And you can clinically clear all the other ones that are okay. This again is a putting it all together slide, but I would actually encourage you to use the infographic provided by PECARN. If you go to their website, it also gives more information about how to apply it. But much like you have those nice PECARN infographics for the head injury rules, I think this should be hung up in every emergency department that sees kids for potential neck injuries.